Today, we will be discussing a renal replacement therapy. You see, when the kidneys fail, may it be because of acute kidney injury, which is or chronic kidney disease, and especially patients when they land up in end-stage kidney disease, there is no other option but to do a renal replacement therapy. Now, in renal replacement therapy, we will be discussing its definition, the types of renal replacement therapy like hemodialysis and its types, peritoneal dialysis and its type, renal transplantation and its types. Then briefly, we will be discussing the principles of hemo and peritoneal dialysis, indications, contraindications. What are the prerequisites? What are the requirements to perform a successful hemo or peritoneal dialysis? How the procedure is performed, possible complications of all the procedures, and finally the summary. Now here I would like to emphasize that these all are highly technical and practical procedures. And unless and until you see it actually being done, it is very difficult to appreciate the different things which are done in these procedures. Anyway, I will try to show you the photographs so as to give you some orientation about these procedures. Now, renal replacement therapy is a term used to include life-supporting measures for kidney failure, and it includes dialysis and transplantation. Now, renal replacement therapy does not cure the primary kidney failure. There is no way once the kidneys are destroyed, you can correct it or you can restore them. So that's why it is called renal replacement therapy. It is not the renal treatment. It is the renal replacement therapy. It only attempts to replace the kidney functions. And you see, there are many kidney functions. Few of them are replaced, for example, excretory function, removal of urea and creatinine. But then there are other functions which needs to be supplemented with renal replacement therapy. It is usually performed when the GFR is less than 15 ml per minute, and it is definitely performed in all patients with a GFR of 10 or less. Dialysis, may it be hemodialysis or peritoneal dialysis, can be used in both acute and chronic kidney disease, but kidney transplantation is only available for patients with end-stage kidney disease. You cannot perform or attempt to do a kidney transplantation in a patient of acute kidney injury in whom there is a potential for recovery of kidney function. Now, these are the modalities: hemodialysis, peritoneal dialysis, and renal transplantation. Now, first we will start with hemodialysis. This is the procedure which is most commonly used in this part of the world. In Pakistan, hemodialysis is the main modality of treatment for patients with end-stage kidney disease, and of course in patients with acute kidney injury. Now, word hemodialysis means a separation. Hemo and dialysis. Hemo is blood and dialysis means separation. So you are separating certain things which are toxic or harmful to the blood with the help of some procedures. Now, there are many types of hemodialysis. As far as you are concerned, you only have to understand acute hemodialysis and chronic intermittent hemodialysis, or it is also called maintenance hemodialysis. Now, all these other procedures are highly sophisticated, and these are not meant for you. For you, acute hemodialysis and chronic intermittent hemodialysis. Now, what are the principles involved in the procedure of hemodialysis? Very basic and simple principles are involved, like osmosis, diffusion, convection, adsorption, and ultrafiltration. These are the basic principles. And how do we achieve these things? Osmosis, diffusion, convection, adsorption, and ultrafiltration. We have to have a semi-permeable membrane. And this semi-permeable membrane is a dialyzer. And you have to create a concentration gradient so that separation can take place. And for that, we use dialysis fluid. Now, I am sure you have to recall your intermediate and O-level basic physiology of osmosis, diffusion, convection, adsorption, and ultrafiltration. Now, basically, osmosis is a movement of water from lower concentration towards the higher concentration. Now, and of course, it has to be separated by a semi-permeable membrane. Now, this is a basic osmosis procedure from lower concentration to higher concentration. And how does it appear? For example, these salt molecules, they move from here to here, but you have to create a concentration. The classical example of osmosis, a day-to-day example of osmosis is, I'm sure all of you must have tasted the zarda, and sometimes in zarda there are kishmish also, and those kishmish are swollen. So when you dip the kishmish in water overnight, it swells. Now that is the basic principle of osmosis. Now, from higher concentration of water to a lower concentration is diffusion. Again, a day-to-day example is if you open a jar of oxygen in a room, after some time an equilibrium is raised in oxygen disperses all over the jar. You see, this is diffusion from here to here, here, and ultimately an equilibrium is reached, and that is a basic principle of diffusion. Now, convection is slightly difficult to understand. It's the movement of solutes with the flow of the water. It is also called solvent drag. The movement of solute with water flow, the movement of membrane permeable solute with ultrafiltrate water. Suppose whenever you remove water, along with it certain elements which are permeable to the membrane, they move along with the amount of water, and this is called solvent drag. Solvent खींचता है बाकी elements. Adsorption is suppose this is a semi-permeable membrane, and there are two types of absorption: physical absorption, the elements come and stick to it, or chemical absorption. A chemical reaction takes place and things get adsorbed on the membrane. Ultrafiltration is the procedure by which, when you apply pressure to one compartment of semi-permeable membrane, the water oozes out to the other compartment, and this is called ultrafiltration. You have applied the pressure on one compartment. Suppose, say, you have applied the pressure on the blood compartment, and solutes move out to the dialysate compartment. And these are the basic principles. You don't have to go into details of it, but at least you should know the basic principles of hemodialysis: is osmosis, diffusion, convection, and absorption, and ultrafiltration. Now, hemodialysis can be performed in patients with acute kidney injury, which is a temporary form of dialysis. You perform few dialysis and kidney function recovers and patient goes home. And chronic kidney disease or patients with end-stage kidney disease, you do long-term maintenance hemodialysis. Now, what are the indications for hemodialysis? These are very important. These are the absolute indications for initiation of hemodialysis, irrespective of the urea and creatinine. Fluid overload. If somebody is in pulmonary edema and which is refracted to medicines like diuretics, there is no other option. And he is, of course, anuric. In such conditions, there is no other option but to dialyze the patient. Hyperkalemia is a raised, as I have been mentioning you on frequent occasions, that it is a very dangerous electrolyte, and whenever there is serum potassium of more than 6.5 and increasing, and it is not responding to the conventional methods, measures like the use of diuretics, cholesterol resins, or any medical intervention, and it continuously increasing, and the patient is oliguric or anuric, hemodialysis as an indication. And then there are signs of uremia. We have already discussed uremia while we were discussing chronic kidney disease, but few of the signs are very serious. For example, uremic encephalopathy, patient is comatose, uremic pericarditis or pleuritis, and uremic diathesis, that is bleeding disorders because of severe uremia. Most of these patients have got very high urea and creatinine. Metabolic acidosis, we have already discussed. Any patient having a metabolic acidosis of 7.1 not corrected by conventional medical methods needs to be dialyzed. And then there are certain poisons like ethylene glycol, salicylates, lithium, phenobarbital, and in them you have to perform hemodialysis. Then there are drug overdosage, which are drugs which are dialyzable, which are water soluble and less protein bound, can be uh, removed by dialysis. Usually, dialysis is performed when a GFR is 10 ml per minute or less than 15 ml per minute. And the rule of thumb, as I have already told you, that whenever the BUN is more than 100, which is a urea of 220, or if the creatinine is more than 8, in such situations, irrespective of the signs and symptoms or clinical conditions, it is always better to start dialysis. Now, what are the contraindications for hemodialysis? There are no absolute contraindications because now the hemodialysis has become very safe and very safety parameters are available in the dialysis machines, but there are relative contraindications. For example, lack of facility or trained manpower. आपके पास facility ही नहीं है, dialysis की machine ही नहीं है और trained manpower ही नहीं है, dialysis technician ही नहीं है, then how can you perform dialysis? Advanced malignancy, terminal illness, somebody has got advanced malignancy with metastasis all over the body. In such situation, dialysis is usually not done and let the disease takes its own course. Alzheimer's disease or multi-infarct dementia or brain death. If somebody has got Alzheimer's disease, is unable to look after himself, or there is a dementia, senile dementia, severe senile dementia, or if the patient is brain dead, in such situation, hemodialysis is usually not performed. Now, hemodynamic instability. Patient has got shock, low blood pressure. In such situation, first you have to restore, make the patient hemodynamically stable, and then you can perform dialysis. Blood clotting disorders, you have to correct the clotting disorders like elevated PT and APTT or decreased platelet. First you have to correct, then and only then dialysis should be performed. Lack of vascular access, because hemodialysis is the procedure in which blood is involved. You have to take large amount of blood to which needs to be passed to the machines. In such situation, you have to have a good vascular access. And if you are unable to make a good vascular access in such situations, hemodialysis cannot be performed. Patients and family referral, because sometimes these are the procedures which are highly technical and complicated, and severe complications may arise, and of course they are expensive also. In such situations, sometimes the patient refuses hemodialysis or the family says, no, we don't want to have dialysis in such situation. In such situation, you cannot perform hemodialysis. These are the relative contraindications. There is, as such, no absolute contraindication for hemodialysis. Now, prerequisites. Trained manpower, qualified technician, and nephrologist are essential. Hemodialysis unit separate or in the ICU. And the equipment needed is hemodialysis machine, hemodialysis filter, which is also called dialyzer, dialysis solution, AV fistula needle or double Newman catheter. I will be showing you the photograph of these things and blood tubing lines. Now, you see, each dialysis session requires around 120 liters of water. Now, that water needs to be absolutely pure. It should be as good as distilled water. And to procure our RO water, that is a procedure is used, which is called reverse osmosis treatment plant. You have to pass water through different things like KDA filter, dechlorinator, water softener, and RO membrane, and then you get the ultra pure water. To get the ultra pure water of 120 liters, you require 4 times of raw water, that is 480 liters. So in reality, each dialysis session needs 480 liters of water to perform one successful dialysis, which is usually of 4 hours. From this 480 liters, you get 120 liters of ultra pure water. Now then, you also need a vascular access. The vascular access are basically of two types: temporary, mostly for acute kidney injury or patients who have got no permanent vascular access. In them, you have to use the temporary vascular access in the form of IG catheters, femoral catheters, or subclavian vein catheters. The permanent vascular access are AV fistula, AV graft, and permacat. Permacat is not purely permanent, but it can be used for say 1 to 2 years. Most of the time, it is the AV fistula which is the preferred permanent vascular access, and then you need an anticoagulation in the form of heparin. You need to screen patient because this is all related to all the blood. So you have to screen patients for B and C to protect other patients from contracting the disease and also protect the staff of the dialysis unit. Hepatitis B and C screening and vaccination for hepatitis B is mandatory, anticoagulation heparin, temporary and permanent vascular access, and to have ultra pure water. These all are the prerequisites. Now, this is a photograph of a dialysis machine. There are different types of dialysis machines available. As I have already said, unless and until you look at the actual procedure, you won't be able to appreciate the various things performed. This is a dialyzer. It has got thousands and thousands of minute capillaries, and then these capillaries are enclosed in an outer casing. Now, the outer casing is a dialysate compartment, and in these capillaries, blood flow. This is a diagram of a dialyzer. Thousands and thousands of capillaries enclosed in an outer casing. The outer casing is connected through dialysing fluid inflow and outflow. Similarly, the blood from the patient comes to these capillaries. Here, all the ultrafiltration, osmosis, diffusion takes place, and the purified blood is returned back to the patient. Very briefly, I'm trying to explain it to you. This is the composition of typical dialysis solution, which is a bicarbonate dialysis solution. We try to maintain the normal range of electrolyte, except for potassium, which is usually kept on the lower side because most of the patients with kidney failure are hyperkalemic. These are the fistula needles, which are used for as a permanent vascular access. Different gauges. This is a temporary vascular access, which is also called double lumen catheters. You pass it into the large vein of the body. I'll be showing you the diagram. Again, a double lumen catheter, curved catheter, which is usually placed for internal jugulars. Now, these are the blood tubings. You see, dialyzer is connected to the arterial line and the venous line, and the whole circuit is fitted to the dialysis machine. Now, this is a diagram of a blood tubing line, arterial line. You don't have to go into the details of it. It passes, it has got a blood compartment. This specific part of the blood tubing line connects to the roller pumps in the machine, which pushes the blood forward. This is the venous line, which is connected to the lower end of the dialyzer, and the purified blood is returned back to the patient. Now, this is a diagram of reverse osmosis plant. You take water, raw water. This pump provides pressure. It passes through the sand filter, the carbon filter, and the softener. Sand filter removes dissolved solid elements in the water. Carbon filter removes all the chlorine because chlorine can be harmful to the RO membrane. And then water softener removes all forms of salts of calcium, magnesium, and make the water light, soft water. This is then passed through a security filter to the high pressure pump, which gives more pressure to the water, and then to the RO membrane. This is the basic membrane which separates. RO means reverse osmosis. So you reverse the osmosis, and for that you need a pressure, and the purified water is stored in the outlet, which is supplied to the dialysis. This is an actual photograph of a RO plant. Now, this is the basic circuit. This you have to understand. because this is a permanent vascular access, which is called arteriovenous fistula. You take blood from the arterial line, pass it to the arterial blood tubing. From a blood tubing, it goes to the dialyzer, as I have said, passes through the capillaries. And here all the exchange takes place because the outer casing of the dialyzer is fed by the dialyzing fluid. Here, concentration gradient is created and toxic things from the blood are removed into the dialyzing fluid and the purified blood is returned back to the patient. This is a basic diagram of the hemodialysis procedure. Now, the same thing which I have told you is this is the artificial kidney or the dialyzer. We have thousands of capillaries. This is the dialysis solution concentrate. These are the blood tubing lines, arterial and venous. Dialysis fluid tubing lines, these are the dialysis fluid tubing lines, and this is the blood pump which forces blood to the dialyzer. Now, this is a patient enjoying dialysis, looking into her computer and relaxed, and dialysis is being performed. The dialyzer blood is taken from the patient, passes through the dialyzer, dialysing pump, and returned back to the patient. Now, this is how you place this temporary vascular access. This is a subclavian vein catheter. You place the catheter, locate the subclavian vein with an introducer needle and then pass the catheter into the subclavian vein. And this is the internal jugular catheter, which both of these are the temporary vascular access, which is usually done in emergency situations. This is how internal jugular catheter is passed. Once you pass the internal jugular or subclavian catheter, you have to confirm the position of the catheter, and for that, X-ray chest is mandatory. After passing the catheter, you have to do an X-ray chest so that you locate that the catheter is placed in a right position. There are many types of complications which can occur during the placement of catheter, like hemothorax, pneumothorax, bleeding, etc. And catheter, instead of going into the subclavian vein, it goes up. So these are the potential complications, very serious complications which can occur while placing the catheter. Now, this is the femoral catheter. You palpate the femoral vein, place the catheter, and secure it. Then it can also be used for temporary as a temporary vascular access in emergency situation. Now, this is a photograph of AV fistula, which is a permanent vascular access. They have placed its AV fistula needle on arterial line and the venous line. Now, this is how a fistula is made. You connect an artery with a vein, and then you close the sutures. The arterial blood goes into the veins and creates a high pressure. And these veins become prominent because in fistula, it is not the artery which you puncture. You still puncture the veins, but you divert the flow of blood from artery to the vein so that there is a high pressure of blood in the veins. This is a diagram of AV graft. In this, you are actually connecting the artery and vein together. It is usually the brachial artery and cephalic veins. And in graft, you place a graft between the artery and the vein. This is a natural thing. This is an unnatural thing. But in some situations, when you are unable to anastomose the artery and the vein, you have to place the graft. Now, this is, you see, when AV fistula is made, the blood flows from artery into the veins, and these veins dilate. They become high pressure system. And usually, once the fistula is made, it requires 6 weeks for the maturation of the fistula. That is arterialization of the veins, the thickening of the veins, the dilatation of the veins, so that they can become prominent and can easily be used for dialysis. This is a diagram of arteriovenous graft. This is the diagram of bridge graft. You place a round graft between the artery and a vein. One is used as a dialysis arterial blood line, and other is used as a venous blood line. It is in most of the dialysis, you see there is mixing of blood, arterial and venous blood. That's why you have to keep on doing dialysis so that blood rotates through the machines and purifies as much as possible. Now, these are the different types of vascular access shown. subclavian catheter, internal jugular catheter, AV fistula, AV graft, and this we will be discussing peritoneal dialysis. This is a internal jugular permacath, which is used as a sort of a permanent catheter, which can be used for a considerable length of. Usually, the temporary vascular access lasts for 3 weeks to 4 weeks, but permacath can be used for up to 1 to 2 years, because in this you use a long tube which is cuffed in the subcutaneous tissue, so there is less transmission of the infection from the skin. This is the basic circuit. I have already told you various safety measure. You take blood from the patient, arterial pressure you monitor with a meter. Then there is a blood pump which pushes the blood and gives it more pressure. From here, it passes to the heparin pump. Heparin is injected so that there is no clotting. Then it goes to the dialyzer, thousands of capillaries, and from here all the exchange takes place. There is a purification. The dialyzer are also called artificial kidney, and then the purified blood is taken up by the venous line. Here again, the venous pressure is monitored. If there is any air in the system, air trap or air detector captures that air. Then if there is air embolism, this air detector trap immediately clamps the blood tubulin so that the air does not go into the patient, which can be catastrophic, and filtered blood is returned to the patient. You see, I have been telling you that these are the highly technical procedures, and you have to actually see it to appreciate the various things which are done in dialysis, the patient having dialysis. Now, how much dialysis do we require? Frequency is dependent on patient's clinical stage. But whenever you start dialysis, it is always better to go modestly. The first session is of 2 hours, then the second session is of 3 hours, and then either you give a 1-day gap and perform a 4-hour dialysis, or even if you do a dialysis on the third day, it should be a very soft dialysis, no hard blood flow rate, no rapid ultrafiltration, no rapid clearance of the urea and creatinine. Why? That I will be telling you. And end-stage kidney disease, once or twice per week dialysis is absolutely not recommended. Once the kidneys have failed permanently, patient needs to have 3 times a week dialysis, each session of 4 hours. Home dialysis, not in this part of the world. Few patients are having their home dialysis, but it's a common practice in Europe and the UK. Nocturnal dialysis is a form of dialysis in which this is also a form of home dialysis. Patient hooks himself to the dialysis machine in the night and then removes itself. This is basically a type of daily dialysis. Now, how do you write the dialysis prescription? You have to mention the length of dialysis session, the type of dialyzer you are using, and its surface area. Larger the surface area, more the clearance, how much amount of blood flow rate you want to have, what is the dialysate flow rate, dose of heparin, the bolus dose and the continuous infusion, ultrafiltration, how much amount of fluid you want to remove from the patient, and the type of dialysis solution, may it be acetate or bicarbonate, and any special instruction pre-dialysis, intra-dialysis, or post-dialysis. Now, how do you check the adequacy of dialysis? A very simple method, urea reduction. This is the amount of urea, how much of urea you remove from each dialysis session. What you do is you divide the pre-dialysis BUN from post-dialysis BUN, and then divide it by pre-dialysis BUN multiplied by 100. The target urea reduction ratio should be around 70%. If you achieve a 70% urea reduction ratio, it's satisfactory. And then there is a sophisticated method of urea kinetic modeling, KT/V, where K is the dialyzer urea clearance, T is the session length, and V is the urea distribution volume. The target KT/V is 1.3, and to calculate KT/V, many calculations are available on the calculator and on net. You just have to feed in the values. The procedure is performed. Pre-dialysis patient clinical assessment is mandatory. You have to prepare the vascular access, may it be temporary or permanent. Pre-dialysis sampling, if you want to take, you have to initiate the dialysis, set the machine parameters. You have to monitor the patient during dialysis, vitals and complications. You have to keep a watch on the alarms and corrective actions which gets activated when the machine is in some sort of problem. Then you have to terminate the dialysis. post-dialysis sampling, you have to secure the vascular access, and post-dialysis clinical. This is the sequence of events which should be done on each patient having hemodialysis. Now, what is the purpose of hemodialysis? You want to make the patient so healthy that he should be as good as of a normal person, near normal quality of life. He should be, once the patient is on dialysis 3 times a week on a regular basis, he should be as good as a normal person. The aim is to rehabilitate the patient. Whatever he is doing, he should start doing that, going to office, practicing, doing labor work, anything. He should be rehabilitated. And this can be achieved by adequate dialysis. Compliance is mandatory 3 times a week. Patients need to be educated for fluid control. Adequate nutrition is necessary. Cardiovascular health, prevent infections, correct bone disease. Now, these are the things, bone disease, anemia, these are not corrected by dialysis. Similarly, psychological support, you have to give a lot of psychological support to the patient, and financial support, of course, hemodialysis and the expensive procedure. It is beyond the reach of common man. And you have to have financial support in the form of government, philanthropy, or NGOs. The complications of hemodialysis, this you should know. Hypotension, because you are removing fluid from the patient. There are chances. This is the most common complication of hemodialysis. Nausea and vomiting, cramps. Yes, they can be very painful to these patients. Then pyrogen reactions because of contaminated water or fever. It usually manifests as fever and rigor. Pruritus, itching can also be a sort of a reaction to the dialyzer membrane, and dialysis reaction. This is also a first use syndrome. First use syndrome, you see, all the dialyzers are sterilized by an sterilizing agent, may it be gamma radiation or ethylene oxide. And if they are not removed before the initiation of dialysis, patient can develop first use syndrome. It is a serious condition. And then there is a dialysis disequilibrium syndrome. You see, patient comes to you for dialysis with a urea of 400, and you try to remove as much as possible. Then it leads to the accumulation of fluid into the cerebrum, leading to cerebral edema and dialysis. This we will be discussing at the time when I take the lectures on hemodialysis. Hemolysis can occur, blood loss can occur, clotting of the blood. There is, if heparin is not adequately used, cardiac arrhythmias and embolism kinds of potential complication, air embolism can occur, and then there is the vascular access failure. These are the a few common complications which are observed during hemodialysis. Now, this was all about hemodialysis. As I have said, that if any of you is interested in observing the procedure, they are most welcome. We have got our own dialysis unit at United Hospital. That's a big unit. Any of you as a group can inform me, and we can take the dialysis unit. Peritoneal dialysis is another form of dialysis. It is an intracorporeal form of dialysis. Intracorporeal means that no machines are used. The patient's body itself acts as the machine. It's a simple procedure, but underutilized. In Pakistan, very few centers, in fact, none of the centers, just recently, CAPD has been started, but it is a very old procedure. We used to perform it as a routine, but somehow it is out of fashion and people are not using peritoneal dialysis. Ideal for patients with no vascular access, because in peritoneal dialysis, you don't need any sort of vascular access, and patients with hemodynamic instability are also candidate for peritoneal dialysis. It can again be of two types. Acute peritoneal dialysis for acute kidney injury, which is temporary. Long-term therapy can be in the form of continuous ambulatory peritoneal dialysis, famously called CAPD, or continuous cycler-assisted peritoneal dialysis, CCPD. CAPD is a very common term nowadays, and it's a main modality of treatment in many parts of the world, especially Canada, Hong Kong, and Mexico. Now, what is the principle of peritoneal dialysis? Instead of having a vascular access, what you do, you use a peritoneum as a semi-permeable membrane, because peritoneum has a large surface area and profuse blood supply. So you use peritoneum itself as a semi-permeable. In hemodialysis, we use dialyzer, but here peritoneum is used as a semi-permeable membrane. Same principles are used: osmosis, diffusion, convection, and ultrafiltration. This we won't be discussing further. What are the advantages of peritoneal dialysis? It is easy without sophisticated equipment, can be done at home by patient himself or family members. Self-care is very important in successful peritoneal dialysis program. It gives more independence and mobility to the patient. It's a treatment of choice in young children and infants because in them it is very difficult to have a permanent or a temporary vascular access. It has got plenty of part cardiovascular benefits because it controls the volume and the blood pressure is adequately controlled in peritoneal dialysis. In fact, it is a more physiological, steady, continuous process. Less dietary restriction, low risk of blood-borne disease like hepatitis B and C, and it avoids frequent hospital visits, may give a better quality of life, provided it is done in a recommended way. Now, acute peritoneal dialysis you do with polyurethane procure catheter, which is temporarily placed. It can be immediately used, and it is very easy to place a temporary catheter in the abdomen just below the umbilicus. You give a neck, pass the catheter, and connect the patient. Chronic kidney disease, you need Tenchkov catheter, which are silicone radiopack with two cups. It is surgically placed. Various types of Tenchkov catheters are available: straight, curved, swan neck, Toronto Western, and it can be used once the surgery is performed. They can be used for after 7 days of the placement. These are the different types of Tenchkov catheter: standard straight Tenchkov catheter, swan neck catheters, curl type catheter, and Canada catheter. But here, what we have got the experiences of only two types: standard Tenchkov and swan neck catheters. These all are placed to decrease the complications. Now, how the catheter is placed, you have an entry point, you pass the catheter, then you exit it through another point. It is subcutaneously placed. This is the curved catheter placed into the peritoneal cavity, and it is secured with two cups. This is the actual patient having a Tenchkov catheter placed in Tenchkov catheter. Now, acute peritoneal dialysis, you place a temporary catheter, you place the fluid into the peritoneal cavity for 15 minutes. It is called infusion time. Then you keep that fluid into the peritoneal cavity so that osmosis, diffusion, ultrafiltration, absorption takes place. And it is called a dwell time, in which 30 minutes. You pass the fluid into the abdominal cavity, peritoneum, and then you keep it there for 30 minutes. And then there is the outflow. You drain that fluid by under gravity, and it usually takes about 15 minutes. The whole cycle is of usually 1 hour, 60 minutes. And these cycles in acute peritoneal dialysis are continued for 24 hours, 36 hours, 48 hours, 72 hours, depending on the clinical response of the patients. Potassium chloride is usually added to the dialysis to avoid hypokalemia, and for rapid ultrafiltration, you make the dialysis fluid hypertonic. You add more sugar to it, so it becomes hypertonic and more fluid is removed. This is the basic circuit of the peritoneal dialysis. This is abdominal cavity, peritoneal cavity. This is the dialysing fluid. You place it under gravity into the abdomen. You hold it in the abdomen for 30 minutes, and then you drain it under gravity into the outflow dialysing bag. Inflow and outflow. This is the catheter, and this is the dwell time, which is 30 minutes for acute peritoneal dialysis. Bag goes into the peritoneal cavity, retained there for 30 minutes, and then drained. CAPD or CCPD is only for patients with end-stage kidney disease. Infused pre-packed sterile dialysis is infused into the peritoneal cavity by gravity. Empty bag is not disconnected. That same bag is used for the drainage purpose. Dwell time is 3 to 4 hours instead of 30 minutes in acute peritoneal dialysis. Here, the dwell time is 3 to 4 hours. Empty bag is placed on the floor. Dialysis along with ultrafiltration by gravity. You drain it by gravity. Fresh cycle with new dialysis bag started. Usually 3 to 4 cycles are performed in a day. And the strength of the solution, depending on the amount of fluid you want to remove, is dextrose strength 1.5, 2.5, and 4.25. And the volume of the bag ranges from 500 ml to 3000 ml. Aseptic technique is mandatory for CAPD, may it be CAPD, CCPD, or FCPD. Now in CCPD, instead of doing dialysis under gravity, you connect it to the cycler at night so that it performs dialysis by itself with the help of a machine. This is the composition of the peritoneal dialysis fluid, where potassium is kept 2, and you sometimes need to add potassium to it. This is the basic circuit, fresh dialysis solution going into the patient. Once the fluid is transferred to the abdomen, you hold the fluid in the abdomen for 30 minutes and then drain it via a drainage bag. Fresh dialysis solution going into the peritoneal cavity, you taking the transfer set. After some time, it is drained back into another bag by gravity. Both the procedures are by gravity. Fluid goes into the abdomen by gravity and is taken out from the abdomen by gravity. This is a lady performing her own peritoneal dialysis. This is a cycler. Patient just go to the sleep, connect itself to the machine, the bag, and it performs all the functions of inflow, outflow, and dwell time. This is called cycler-assisted peritoneal dialysis. Now, what are the contraindications for peritoneal? You should be knowing the contraindications. Peritoneal fibrosis means if peritoneum is not in a position to perform ultrafiltration and clearance, it can be because of fibrosis, adhesions, or abdominal hernia. Massive obesity is also a contraindication for peritoneal dialysis. Polycystic kidney, you can damage the kidneys and there could be catastrophic bleeding. So in patients of polycystic kidney, usually peritoneal dialysis is not performed. Recent abdominal or thoracic surgery is a contraindication. Because peritoneal dialysis to be performed with the patient himself. So physical handicap or psychiatric illness is a contraindication for peritoneal dialysis. If patient is severely malnourished, it is a relative contraindication because there is a lot of protein loss in peritoneal dialysis. So a malnourished patient should not be having peritoneal dialysis. Lastly, patients and family refusal for peritoneal dialysis. If they opt for hemodialysis, you have to go ahead with the hemodialysis. Now, what are the complications of peritoneal dialysis? Bleeding after catheter insertion, yes, that can occur. You can perforate the gut, abdominal pain, leakage around the catheter, difficult infusion, drainage, omental flap. You have placed the catheter, you are trying to infuse the blood fluid into the abdominal cavity, but it is not going. The omentum of the abdomen flaps around the catheter, and there is a difficult infusion. Exit site infection, peritonitis is one of the most dreaded and most common complications of peritoneal dialysis. Metabolic and electrolyte imbalance, catheter malfunction, abdominal hernia, hydrothorax, and bladder perforation are the potential complications of peritoneal dialysis. Peritonitis, as I said, is the most common and most serious and most serious complication in a way that you have to sometimes abandon the peritoneal dialysis. How it is diagnosed? The first indication for the peritonitis is the cloudy peritoneal. You see, you are infusing a clear fluid. It should come out clear with all the electrolytes and urea and creatinine. But if it becomes cloudy, then it's a potential for there is a potential for peritonitis. Patient may complain of abdominal pain and tenderness, fever, tachycardia, and toxic, but these things come later. The first indicator of peritonitis is cloudy peritoneal fluid. And PD effluent positive cultures, and if you get these things cultured, they are positive with gram staining. Now, how do you treat peritoneal dialysis? Rapid exchanges to wash out toxins, intraperitoneal antibiotics, and if it is not responding, you may have to abandon peritoneal dialysis and remove the catheter. Now, the key points for peritoneal dialysis is it's an effective form of renal replacement therapy, especially in children and patients with vascular access failure or lack of hemodialysis. Trained and committed nephrologist and nursing staff, because the peritoneal dialysis requires a dedicated patient, a dedicated nursing staff, and of course, a dedicated nephrologist. Aseptic techniques and sterilization is mandatory. You cannot perform a successful peritoneal dialysis made by CAPD or acute peritoneal dialysis without an aseptic technique. It can be used as a bridge before kidney transplantation to avoid blood-borne infections like hepatitis B and C. But the usual time frame of peritoneal, the maximum peritoneal dialysis you can use is for 6 to 8 years, and after that, peritoneum gets sclerosed, and it is called sclerosing peritoneal. So whatever you want to do, if you want to do a transplantation, do it between 6 to 8 years of initiating CAPD, or after 8 years, you have to switch over patient to the hemodialysis. And the last thing which we will be discussing is the renal transplantation. It is definitely, it is a most ideal form of therapy for patients with end-stage kidney disease. For example, गाड़ी चला रहे हैं, टायर पंक्चर हो गया. How many times you will keep on getting the puncture repaired? You see, गाड़ी पंक्चर हो गई, टायर खराब हो गई, you change the tire. It is exactly like that. The kidney खराब हो गई, kidney को change कर दो. The advantage is long patient survival, yes, but survival on hemodialysis and peritoneal dialysis is almost comparable. Less comorbidity, cardiovascular benefit definite है. Renal transplantation का improved quality of life, no need for going to the hospital 3 times a week or performing the CAPD daily. It improves your quality of life, physical and emotional well-being, life satisfaction, ability to return to work. इसलिए अस्पताल नहीं जा रहा तो काम पे जाएगा. Reverse uremic complications, and it also corrects anemia, renal osteodystrophy, and fertility. You see, you have to remember the functions of the kidney. You are replacing the kidney, so the healthy kidney will perform, it will produce erythropoietin, it will activate vitamin D3, and it will definitely improve the fertility. Cost saving in the long, initially it is expensive, but in the long run, it is cost effective. All patients with end-stage kidney disease are candidate for renal transplantation unless contraindicated. Now, what are the contraindications for kidney transplantation? ABO compatibility, because you have to take kidney from somebody else, so you have to have the same blood group. But nowadays, such a strong immunosuppression is available that most of the time ABO compatibility is ignored, and patients with different blood groups can donate patient to the kidney, except with certain limitations. Antibodies, this is important, antibodies against the HLA antigens of the donor. And if there are antibody presence against the antigen of the donor in the patient, then it is called positive cross-match. And this is an absolute contraindication for kidney transplantation. You have to check for antibodies and antigens, and if the match is positive, you abandon the kidney transplantation procedure. Recent metastatic malignancy is a contraindication. If somebody has got active infection like BC, HIV, or CMV, first you have to get rid of it, and then only transplantation can be performed. Severe extrarenal disease may be cardiac, pulmonary, hepatitis, CNS is a contraindication for transplantation. Acute vasculitis or glomerulonephritis, acute nephritic syndrome is a contraindication for renal transplantation. Non-compliance, if you know a patient will not be able to follow the instruction and take the medication, then it is also a relative contraindication for dialysis. Psychiatric illness, including alcoholism and drug addiction, is a contraindication. Primary oxalosis, because primary oxalosis is a condition in which oxalate crystals are found in the urine, and if you transplant in such patients, that kidney will also be destroyed. Elderly patients above 70 years of age with morbid comorbids is a relative contraindication for kidney transplantation. Recurring kidney disease, hereditary nephritis, familial FSGS, some say diabetes also. But you see, if somebody has got a familial focal segmental glomerulosclerosis, if you transplant a kidney into that patient, those things which are causing FSGS will again cause FSGS in the same kidney. It is also called de novo appearance of the kidney. And non-availability, this is the main hurdle in the and is a sort of a contraindication. If you are unable to procure an organ, then it's a contraindication for renal kidney transplant. बगैर organ के तो transplant नहीं कर सकते हैं. Now, who are the types of kidney donors? They are living and cadaveric, dead. लिविंग रिलेटेड भाई बहन माँ बाप में से कोई भी दे सकता है. लिविंग अनरिलेटेड इमोशनली मोटिवेटेड लाइक वाइफ और गुड फ्रेंड एक्सेट्रा. और लिविंग अनरिलेटेड, this is basically an organ trait. This is all commercial and it is unethical. कैटेगरिक ट्रांसप्लांट डेड बॉडी में से अगर या तो ब्रेन डेथ हो, हार्ट बीटिंग है, फॉर एग्जांपल पेशेंट इज ऑन वेंटिलेटर, ही हैज साइंड अ कंसेंट फॉर डोनेशन एंड ही इज ब्रेन डेड but heart is beating and interactive function. In this situation, brain death can be if the consent is available, kidneys can be procured from these patients for transplantation. And non-beating heart is a actual death, donation after cardiac death, and this can also be done. But the results of brain death, beating heart transplantation are relatively, the results are better as compared to DCD. How do you select donors? ABO blood group compatible, preferably यही होना चाहिए. Tissue typing, you have to type the tissue for negative cross match between the donor and the recipient. Highly motivated family or emotional donor, no commercial donor, normal renal function and no comorbid. The donor की कोई comorbid usually नहीं होनी चाहिए और कोई renal function 100%. For this, donors need to be screened thoroughly for any comorbid condition or kidney disease. Screening for hypertension, proteinuria, obesity, and kidney stones, for structural and functional kidney diseases, screening for latent diabetes mellitus, screening for hereditary disorders like polycystic kidney, familial PSGS, and all these things are done. Screening is done by detailed history, clinical examination, number of tests, and imaging techniques, including tomography and angiography, renal angiography. And once all these three things are normal, only then donor is selected for transplantation. Recipient selection, general medical condition of the recipient, he should be relatively in a better medical comorbidity. Previously, they used to refuse transplantation to diabetes, but if the diabetes is well controlled, yes, now transplantation is offered to them. In fact, in diabetic patients, kidney and pancreatic transplant is the ideal treatment. ABU and HLA typing is very essential. Cardiovascular screening for hypertension, ischemic heart disease, cardiomyopathy. Hereditary disease and polycystic disease, yes, you have to screen for that. Screening for cancer is important. Pap smear, mammography, colonoscopy, and prostate cancers. Presence of preformed antibody, this is an absolute contraindication for transplantation. Psychological evaluation and functional evaluation of urinary tract is also important because you are implanting a kidney and connecting it to the urinary tract. Tissue typing, very briefly about the tissue typing. It is a major histocompatibility complex, and it is also called MHC. It expresses on cell surface molecules. It is crucial for immune system recognize and respond as foreign antigen. कोई भी foreign antigen आती है, histocompatibility complex जो है उसको identify करता है. MHC are located on the short arm of chromosome 6. in हर सेल के अंदर क्रोमोसोम 6 के शॉर्ट आर्म में मेजर हिस्टोकम्पैटिबिलिटी कॉम्प्लेक्स लोकेट होता है एंड इट इज क्रूशियल फॉर इम्यून सिस्टम. It encodes for protein called HLA, human leukocytic antigen, perform two basic functions. Identify self from non-self. अगर वो बाहर का कोई एंटीजन आ गया है, HLA will recognize it and will reject it. It coordinate with T cell receptor response for HLA MSC complex, and this is basically a lymphocytic response, late response. MSC molecules are divided into two groups. Class A antigen, basically they are 6, but we will, for tissue transplantation, HLA-A and HLA-B are important. These are expressed on surface of most nucleated cells, and type 2 antigen, which is called HLA-DR, these are expressed on surface of antigen presenting cells or activated lymphocytes. For kidney transplantation, only HLA-A, B, and DR are used, and zero antigen mismatch has no mismatch either for HLA-A, B, or DR, and they are the ideal candidate. There is no mismatch for A, B, or DR. Two types of match are also acceptable. Suppose if somebody has got a match for HLA-A and HLA-DR, yes, he can be accepted. Similarly, HLA-B and HLA-DR, it is accepted, but DR has to be there. A match for DR has to be there. Otherwise, there are chances that more chances of rejection. At the transplantation, you cross-match between recipient and donor, which is called cross-match. If the cross-match is positive, you cancel surgery. For induction, you use high-dose steroids or anti-thymoglobulins. Donor nephrectomy is performed usually the left kidney because left kidney has got longer renal vein. Transplant surgery, kidney is placed in the iliac fossa. Renal artery and vein are connected with external renal artery and vein. Ureter are implanted into the bladder, and there is an instant prompt urine formation. In fact, on the operation theater table, and that is a good sign that patient is producing urine once the kidneys are transplanted. Yes, these patients need immunosuppression, which is usually indefinitely large doses in the early period. There are various types of regimens available. Induction is with glucocorticoids or ATG. Maintenance is with cyclosporin, azathioprine, and corticosteroids. Various new drugs are also available now, MFF and other drugs. Treatment of rejection, high dose steroids and ATG, intravenous immunoglobulins. It depends on the allograft biopsy, transplanted kidney biopsy, and sometimes as an acute measure, you also have to perform plasmapheresis. The complications can be divided into early and late. The early complications of transplantation are surgical leak, thrombosis. This is not lymphocyte, it is a lymphocyte, and hematoma. Delayed graft function, DGF, which can be acute tubular necrosis or acute rejection. Now, acute rejection can be of three types. A rejection occurring within 1 day is hyperactive, or it is also called hyperacute. It is not hyperactive, it is hyperacute. Accelerated within 2 to 3 days, and acute cellular rejection between 5 to 7 days. In all these forms of rejection, whenever a rejection is suspected and acute rejection is suspected, you immediately perform the biopsy. The late complications include infections like CMV, hepatitis B, C, and viruses, drug-induced like cyclosporin, recurrent, and malignancy. And then there are complications of comorbid conditions, the complications of long-term immunosuppressions. Patients with functioning graft often develops complications related to infection, cardiovascular disease, malignancy, diabetes, bone disease, hematologic disease, pregnancy, and treatment non-compliance. Infection, immediate post-operative infection, wound infection, pneumonia, Lyme sepsis, urinary infection. In the first 6 months, opportunistic infections, which cause of intense immunosuppression. Pneumocystis carni pneumonia is a potential risk for these patients. Should be treated with ceftriaxone and dexone. Cytomegalovirus reactivation treated with vancyclovir. Fungal infection, antifungal. BK virus nephropathy, reactivation of latent infection. BK is a specific type of virus which is very closely related to transplantation. Hepatitis B, C, and HIV also increase the risk of rejection. After 6 months, community-acquired infections and pre-transplant screening should be done for CMV, BK virus, etc. Management, mild infection, no change in immunosuppression, severe infection, reduce or stoppage of immunosuppression, life-threatening, add corticosteroids. All admissions are to be treated with broad-spectrum antibiotic with culture evidence. Immunization, yes, pre-transplant influenza, pneumococcus, hepatitis, and varicella vaccination is recommended. But once the transplant is performed, no immunization should be performed for 6 months. There is increased risk of rejection. Poliovirus, typhoid, varicella, yellow fever, TB vaccination are contraindicated post-transplantation. 6 months after transplant, you can use MMR, influenza, pneumococcus, hepatitis B and C, and DPT vaccine. Cardiovascular disease is the most common cause of death in patients who are after a successful transplant. The main reason being pre-existing ischemic heart disease, congestive heart failure, left ventricular hypertrophy, and coronary vascular disease. Uh, in fact, these are common even before the transplant. Hypertension is very common in these patients. 70% beta blocker, calcium channel blocker are usually used for first 6 months. Lipid abnormalities are treated with statins. Salt and water retention due to steroid and cyclosporin is treated with diuretics. One should also watch for the rhabdomyolysis, which is a complication of treatment of lipid abnormalities with statins. They can cause rhabdomyolysis, and not quite smoking. All of these patients should quit smoking. Diabetes post-transplantation is quite common in almost in 35% of patients, mainly because of immunosuppression and use of steroids. One should target HbA1c6, fasting sugar 110, strict control with insulin, weight reduction, diet, routine monitoring after transplantation. Post-transplant diabetes mellitus is a common thing. Malignancy, yes. Most important complication of immunosuppression is squamous cell carcinoma of skin. For this, sunscreen dermatologically review at least once per year. Then there are second most common cause is lymphoma, Epstein-Barr virus, mainly because of chemotherapy. Cervical cancer in women, yearly pap smear is recommended. Hepatitis B and C, hepatocellular carcinoma is seen in almost 12% of patients after transplantation. Kaposi sarcoma, as I have already told, can lead to herpes simplex 8 virus. Renal cell carcinoma can also develop. Breast, lung, and colon cancer, modest elevation. All the transplant patients should be long-term surveillance should be performed in all transplant patients for possible malignancies. Bone disease, yes, they have already got pre-existing renal osteodystrophy, and with the use of steroid, there is increased risk of fracture, avascular necrosis of femoral head due to steroids. Routine calcium and vitamin D supplements are necessary. We have to watch for hypercalcemia and weight-bearing exercise. After transplantation, anemia is only seen in 30% of patients, especially those who have got impaired graft function. The other factors which can contribute to anemia are ACE and ARB, which are used for control of hypertension. MF is a immunosuppressive drug, or azathioprine. They can also contribute to anemia. Post-transplant, in fact, post-transplant erythrocytosis, the raise in hemoglobin is quite common with a PCV of 51% and seen in almost 15% of patients, especially diabetics and smokers, and the treatment is phlebotomy. तो ट्रांसप्लांट के बाद हीमोग्लोबिन 15% पेशेंट में बढ़ जाता है. If pregnancy is allowed 2 years after the transplant, not for 2 years at the transplantation. Contraception during this period, immunosuppression to be maintained. Yes, mycophenolate mofetil and azathioprine are contraindicated if the patient is pregnant. We have to watch for gestational diabetes, increased risk of preterm delivery in almost 50% of any patients, and breastfeeding is not recommended, especially in those transplant patients who are on calcineurin inhibitor, which is cyclosporin. Predictors of successful transplantation are good match on tissue typing, young patient with relatively less complication, living related donors like Ben, Bhai, Maba, young donor, no comorbid condition of the donor, less time on dialysis, and the patient should be educated, should appreciate the type of treatment which is involved. Now, the key points of transplantation is patients receiving kidney transplant live longer. It is more physiological. It replaces all kidney functions. Initial cost is high, but long-term cost is it is cost-effective long-term. Availability of organ is a problem. Cadaveric transplants need to be encouraged. Commercial transplant is unethical and is not acceptable. In fact, laws have been passed in Pakistan that no commercial transplant should be performed, but chup chupa ke abhi bhi ho raha hai. This is a transplanted kidney, usually placed in the right iliac fossa, and these are the diseased kidney. You connect the transplant, the renal artery and vein, and you connect the uh, the bladder, ureter with the bladder. You have to take care of your kidneys to avoid chronic kidney disease and end-stage kidney disease. Otherwise, you may be needing transplantation or long-term maintenance hemodialysis. One has to protect his kidneys. Now, who is she? I am sure all of you must be knowing. She is Selena Gomez. She is a successful transplant patient, having a normal, almost a near normal life. And the donor was an emotional donor, her secretary, I think. This was all about the renal module. We have done almost 10 lectures, starting from the approach to the patient with kidney disease, kidney function test, types of renal syndromes, acute kidney injury, chronic kidney disease, and finally, kidney transplantation. Go through these lectures, come well prepared for your actual lectures so that we may have a fruitful discussion.